This week, I'm going to be moderating this cath conference with Sabida. Sabida Cardiovascular is finally a general cardiology fellow about to start intervention and is a special interest in structural heart. So she'll help moderate your questions at the end through the chat. We're very lucky to have today Eberhard Grube, who I count as a personal friend and among one of my mentors, who's taught me a lot. And I think a real expert in transcatheter interventions, all of them, whether it's aortic, mitral, tricuspid. Eberhard, I think we're all looking forward to hearing you share with us the present and future of transcatheter mitral valve interventions, and hopefully we'll have a lot of time for active discussion at the end with the fellows. Antonio's joining us too, so it should be a great discussion. Thank you, Eberhard.
Thank you very much, Azim and Sabida. A pleasure to see you or meet with you via on the screen, and thank you for inviting me. I would also like to start and thank all the guests that are joining us. I know there are some from South America, some from India. Great to be back again, Azim, and talk about the present and the future of transcatheter mitral valve interventions. This is my disclosure. Obviously, I have been involved both as an advisor and also in as far as investments are concerned in some mitral companies, as you can see here. So the structure of my presentations, I would like to start with some general remarks about primary and secondary mitral regurg, some treatment options for mitral regurgitation, transcatheter mitral valve repair and transcatheter mitral valve replacement, and discuss new innovative solutions, and then bring across some final thoughts. When we started the journey many years ago, end of we thought the mitral is the next TAVI. We were all excited and we thought the speed is the same. Well, unfortunately, that is not the case, as we all know now. Pretty straightforward is aortic valve intervention. And then on the mitral side, we probably underestimated the problems that we were facing. The mitral valve is very special. There's a high variability and instability of the anatomy. It is a complex apparatus with an annulus, leaflets, chordae, papillary muscles, and left ventricle. And the axis is also different: transapical, transatrial, and transeptal. And then, of course, very, very important, the two pathologies, primary and secondary mitral insufficiency. So if we look at the disease prevalence in the United States, you see 4.6 million people with mitral regurgitation more than 2+. 56% of those patients degenerative and 44% functional. 44% of those patients of the 4.6 million have mitral regurg more than +3. Almost half of them severe mitral regurgitation, and another 41% of those is in the age group of the 75 and above. So there are lots of patients with severe mitral regurgitation. And I like to compare the mitral valve apparatus with the card house. Everything stands and works if everything is in place and works well. Once you pull one card, the whole house falls apart. And this is basically the same situation on the mitral valve. It is a various component apparatus, and if one component of those doesn't work well, then we have a problem. And very, very important, and I cannot stress this enough, the two types of mitral disease: degenerative mitral regurgitation, which is basically prolapse of flail, a leaflet disease, and then on the right side, the functional mitral regurgitation, which is basically a ventricular problem. It is important to note, not only in pathophysiology, but also in the treatment options, degenerative mitral regurgitation is not functional mitral regurgitation. Primary mitral regurgitation or degenerative MR is a leaflet problem, usually prolapse, flail, or lacerations. And if we look at the primary mitral regurg, then severity predicts poor outcome. Primary MR is a disease of the valve or the valvular apparatus, and if left untreated, has a very poor prognosis, as we can see on the right side. The more severe the worse the prognosis. The guideline recommendation and treatment options are fairly clear in primary MR. Surgical repair is considered the gold standard for treatment of primary MR, and the surgical treatment options for primary MR are effective and are not really controversial. This is the surgical toolbox: annular rings, leaflet repair technologies, and eventually mitral valve replacement. Secondary MR or functional MR is a ventricular problem, as demonstrated here. The ventricle enlarges, then eventually the ring enlarges, coaptation lacks, and then both ventricle and left atrium enlarges. It is a muscular disease with decreased left ventricular function and lack of coaptation, as you can see here on the echocardiogram. Mortality in functional MR is proportional to the degree of MR, and functional mitral regurgitation makes you die. Even with small amounts of FMR, survival is not really good. The guidelines, as opposed to primary MR, is still open, no recommendations for transcatheter mitral valve repair. So we don't have, up till now, no guidelines on how to treat functional MR on a guideline basis for secondary MR. This is the traditional cardiologist's view of FMR, poor understanding of the disease and treatment options, and it isn't really much fun. The enlightened cardiologist's view on the right side of FMR: now we understand the disease better, we have more treatment option, and it is actually more fun. So let's start with mitral valve repair. Those are the devices in humans. Some of them we will discuss. And those are the mitral repair devices in use. And as you can see, for the most part, on the left side, the mitral clip, obviously, followed by the Carillon device, Cardioband, and then Pascal. A number of devices targeting the mitral valve leaflets, caudal apparatus, and mitral annulus are under development. Overall, TMVR repair devices show good safety outcomes, but improvements in ease of use and efficacy are still required. You can see here the targets, the devices, the description, main indications, the status, and reported cases. So let's start with the mitral leaflets, clip, and Pascal edge-to-edge devices for primary and secondary MR. We all know the grand hero, Professor Alfieri from Milan. This technology imitates his technique, although there are some differences when he used it and how we're using it today. There are randomized clinical trials with the mitral clip, the Everest study, focusing on primary mitral regurg, mitral FR studies, secondary, and COAPT, secondary mitral regurg, all three published in the New England Journal of Medicine. You all know the results, so we don't need to discuss this. I want to bring some new aspects here to your attention. We know this is a great technique, the clip, particularly in the elderly, but I would like to add some words of caution. We have to make sure, looking at the STS ACC clip TVT registry, that at that time, in about 3,000 patients, 40% left the hospital with MR more than 2, and the hospital mortality was 2.7%. That is not what we would like to see. And obviously, the clip data so far have gotten much better. And I would like to bring to your attention the study of the Global Expand study that was presented at ACC this year, the contemporary outcomes with the clip, NTR and XTR, presented by Scott Lim. This is the background and the evolution of the mitral clip, and you can see on the right side NTR and XTR with an improved delivery system on the XTR with the longer arms. The overall study subject population, as shown here, 1,000 subjects consented and underwent clip implantation. 835 had adequate imaging for echocardiographic core lab assessment, and 422 subjects with primary or mixed etiology, and 413 for secondary MR. He presented the 422 subjects with primary or mixed etiology. Those is the complexity that was adjudicated by the Echo Core Lab, and you can see here the complexity of the mitral valve anatomy in 404 patients. 71% were non-complex and 29% had complex anatomies, basically primary jet outside A2P2, presence of an extremely wide jet, calcification landing zone, presence of severely degenerative leaflets or wide flare gaps or width. The mitral clip type used in this study with primary MR are shown here, XTR in close to 50%, the NTR in 34.8%, and in 19% both. XTR was used more frequently to treat primary MR as compared to NTR. And now we can see the procedural outcomes comparing it to the previous trials, prohibitive risk, primary MR, and TVT registry. On the right side, you can see expand primary MR in those 422 patients. Implant rate in percent, you can see 99.5%, very good data. Acute procedural success in 94%, went up from the TVT registry that we just briefly mentioned. Fluoroscopic time also came down from 39 in the prohibitive risk to 18 minutes. Procedure time also came down from 134 to 82, very good, and length of stay in the hospital for index procedure, very low also as compared to prohibitive risk and TVT registry. So overall, we can see in this cohort with more experience of the operator and better devices, the numbers are coming down and are very, very promising. Those are the 30-day major adverse events. All-cause death, 2.4%, stroke, 1.2%, non-selective CV surgery for device-related complication, 0.9%. And these here are the device-related leaflet adverse event, basically single leaflet device attachment, SLDA. In those 422 patients only, this occurred in 8 patients. Leaflet injury, leaflet tear, or perforation only in 1 patient, and they were all adjudicated by the respective committees, which is an excellent result. And this is also very, very, very good news. And you can see here the adjudicated MR severity. The MR reduction to non and trace was achieved at 27.7% primary MR subject, and MR less than 1+ was achieved in 86.9%. Very, very good results, as you can see here. And this is also good news. Left ventricular remodeling, looking at the left ventricular dimensions and volumes at 30 days versus baseline. Now, we do have early data, as you see here, and I would like to show you that this is actually early evidence of a reduction in left ventricular dimension and volumes, probably the early signs of ventricular remodeling that we haven't seen so far with any of the devices, except for another device that we will discuss later. So in conclusion, then, I would like to say that this study represents the first contemporary report of ECL and CEC adjudicated 30-day clinical outcomes in patients with primary mitral regurgitation treated with the next generation mitral clips. Approximately 1/3 of patients had a complex mitral valve anatomy that reflects the difference in patients treated in the real world in comparison to past clinical trials. Results show that MR less than 1+ is being achieved more often with NTR and XTR than previously observed in the Everest 2 trials. And mitral XTR was associated with greater MR reduction compared to NTR in more complex anatomy. Moving on to the Pascal device, this is also Edwards edge-to-edge repair. It has a spring-loaded paddles and 10mm central spacer. Is obviously a transeptal approach. And also we see here 30-day outcomes of the CLASP early feasibility study showing significant improvements in MR severity, neurofunctional class, and quality of life. So the Edge technology is very promising, moving on with more experience and better devices. So what is then the mitral world after COAPT? Increased optimism with mitral valve therapies. Trial recruitment for other devices will become problematic. If the clip becomes standard of care, it might become competitive for other mitral innovations. Heart failure specialists are now more actively involved. Safety of the clip procedure will be difficult to match, and the results of the COAPT trial are difficult to replicate in all patients. So I believe more devices will be needed. Surgery remains an option for DMR in younger patients and more complex anatomies. Move on to annulus mitral valve repair systems in erect annuloplasty, the Carillon mitral cerclage MVR, ventricular repair, the Anticoagulation device, and then direct annuloplasty, Valcare, cardiac implants, Edwards Cardioband, and Boston Scientific's Millipede. So moving on then to the focus of the mitral annulus, basically, as I said, Carillon, Cardioband, and Millipede. Carillon, coronary sinus, Cardioband, and Millipede direct annuloplastic in secondary MR. Carillon and Cardioband are CE marked, Millipede is not. The Carillon mitral contour system is a very simple right-sided procedure, 9 French, cinches the mitral apparatus via the coronary sinus, preserves future therapy options, and over 1,100 implants have been done to date. This is the deployment and the cinching. Basically, you can see the coronary sinus, you implant the device, the distal anchor is deployed, the proximal anchor is deployed, and then the sinus is cinched. The beauty of this device, at least in my view, it is independent operator with clinical specialist after three procedures. So the learning curve is very, very low. The technique does not require surgical backup in the room. The procedure time usually less than 100 minutes, conscious sedation an option per IFU, and the ability to approach smaller centers in the world to target patients early in the disease process. This is an example. Over time, you can see here before and after 1 month. It is noteworthy that the most experienced operators do not build on the acute results. They wait for 1 month, then they control it. And this is how it's being done in the pivotal trial also. There has been significant clinical evidence in the Titan trial and the reduced FMR trial. And what you can see here, if we look at the pooled studies, the change in mitral regurgitation grade, the implanted patients show MR improvement among all MR grades with an augmented response in patients with more severe mitral regurgitation. And if we look at the reduced FMR in comparison to COAPT or MITRO-FR, then we can see only Carillon decreased the left ventricular end diastolic volume, which is an indicator for positive remodeling. As you can see here on the left side, reduced FMR, COAPT in the middle, and MITRO-FR on the right side. And if you look at the lower part in red, you can see the relative changes. So we do see with this device over time, beginning at 30 days up to 6 months, a positive remodeling with reduction of end diastolic volumes. And if we look at the all-cause mortality comparing Carillon to GDMP and COAPT over 3 years, you can see Carillon compares very favorably with guideline-directed medical therapy alone or with the mitral clip as shown here, 43% mortality in the clip population and 33% in the Carillon population. This is the study that's designed in the United States. It has been revised after the clip results, and you can see here basically it is in the beginning Carillon versus medical therapy, 6 month follow-up. Then the patients are being evaluated. If there are no improvement of symptoms, depending on the team decision, alternative therapies are being recommended. If we see improvements in symptoms and data, then we continue the follow-up and then will be a continued blinded follow-up. So interesting new study on the way in the United States. Moving on to Ancora. Ancora is very specific, and obviously I'm talking to the master here, Azim and Uli, who are deeply involved with this technology. AccuCinch ventricular repair system is aiming at the treatment of heart failure with reduced left ventricular ejection fraction. And you can see basically here the procedure. You access the left ventricle, you implant the delivery, you deliver the implant, and then you cinch subannularly in a predefined percentage. And we can see here, if we look at the worldwide implants over the last 8 quarters, we see dramatically rising numbers, which is promising both in terms of results, hopefully, and also in terms of ease of use. And you can see here very robust 5 approved clinical studies in patients with heart failure and reduced ejection fraction as shown here. And you can see here CoreCinch FMR has been completed. You can see here on the right side with Uli and Azim, CoreCinch heart failure reduced EF in 30 patients as principal investigators. If we look at the CoreCinch pivotal subgroup in 34 patients with an ejection fraction between 20 and 40, basically the mean was 30, and diastolic dimension more than 55, and MR 2+ or less, you can see very promising KCCQ data over time, and you can see 6-minute walk test changes from baseline, and also you can see here then the pivotal study in the US, very complex, but very promising. I think the company is doing great, focusing on heart failure. As you all know, we don't have very many device approaches for this disease. Then we come to the direct annuloplasty. You all know the Edwards Cardioband, implanted via transeptal approach. It is basically a supraannular ring fixed by anchors. You cinch, and it preserves future treatment options because it doesn't interfere with the leaflet. Here you can see the cardioband effect on the left side before cinching and on the right side after cinching. It has been tested in Europe and in the United States. You can see here results of the CE mark study showed a reduction in MR with 92% of patients experiencing MR less than 2 at 2 years out. Cardioband reduces also the average septal lateral dimension by 30%. Boston Scientific's Millipede Transcatheter Annuloplastic Ring System is a ring that we know from surgery. It's a complete ring, customizable, repositionable, and retrievable. It does have a transeptal axis. Basically, it is being anchored in the annulus and then cinched. And you can see here how it works, transeptal approach. You open up the tree, you approach the annulus, the intracoronary catheter is being moved. You can see scanning. So you place the anchors according to the ICE criteria, and then you cinch the device once it is good in place. You can see here 2D and 3D echo positioning. I don't need to explain this. It's quite obvious what's happening here. So it is a very controlled delivery of this device. And this is one of the first patients that we've done with this device in place, basically removing and abandoning mitral insufficiency. And then the last would be the caudal approach, or the aim of the caudal apparatus, neocord, harpoon, and I would like to also add pipeline. Neocord, shown here, transapical. Delivery grabs the leaflets and fixes the mitral valve leaflets to the left ventricular apex, as shown here on the picture, received CE mark in 2012. So it has been around for a while, and the experience with neocord is relatively large. Early European experience in 213 patients helped to identify those patients who are most likely to benefit from caudal repair with this particular system. As you can see here, type A, type B, type C. Obviously, type C is the most complex. Type B is disease not only related to P2, and type A is related to P2, and this is actually the best result, as you can see here. The NeoCord prospective record trial is underway with 60 non-randomized roll-in patients, 450 randomized patients, NeoCord versus surgery, and 75 non-randomized high-risk registry patients. Harpoon, Edwards harpoon approach, transapical access also, low profile, preformed the knots. The knots are formed on the atrial surface of the mitral leaflet, and it's also anchored in the apex. The Harpoon EFS and Tracer CE mark trial showed fairly good results with significant MR reduction out to 2 years. In April 2018, however, Edwards decided to temporarily pause the study enrollment until the potential root cause of some recurrent mitral regurgitation and conversion to surgery are better understood. Last, I would like to present to you something new, which is the chordal replacement pipeline, a Gore company. It is a transfemoral transeptal approach. Familiar 24 French venous catheter, Gore-Tex cords and leaflet pledgets. It anchors, it does not anchor in the apex, it anchors in between the papillary muscles, and the cord length is adjusted under TEE control. No mitral stenosis is left, and it preserves, obviously, future options. These are the procedure. As you can see here, the anchors are placed, and you can see here the two papillary muscles. The anchor is placed in between the papillary muscle, which shortens the length of the chordal, artificial chordae, the Gore-Tex chordae. Then the leaflets are being attached, adjusted by TEE control, and then locked and cut. Those are the 4 steps that are being followed in this procedure. You can see here a very nice result, actually, in both views. There is no, in this patient with a flail leaflet, the chordal apparatus is holding and the mitral insufficiency is abandoned. This is the procedure. You can see here, the anchor is in between the papillary muscles, not going out to the apex. This is the patient that has been done. The first patient, he was extubated on the table, no MR left, and there was an 8 millimeter coaptation zone. The whole procedure lasted 2 hours and 20 minutes. So overall, if we look at the repair devices, they show good safety outcomes, but improvements in ease of use and efficacy are still required. Moving on to TMVR, mitral valve replacement. I believe transcatheter mitral valve replacement will be a key therapy for MR patients with evidence to prove safety and efficacy. TMVR valve design will address current limitations eventually, and along with other procedural improvements such as imaging and transeptal transfemoral access, will help make the procedure easier. Those are obviously the procedure and design goals. Most importantly, safety, efficacy, and ease of use with reduction and elimination of MR, no remaining PVL, preferably transeptal transfemoral access, minimal anatomical exclusions, and obviously predictable deployment. Those are the devices out there beginning 2012 out to 2019. I should say Tendyne has recently been CE marked. All the other devices are not being CE marked. Some of them are resting in peace, as shown here, and the remaining are working on the studies. So we have transapical and transeptal devices. Let's go on first to the challenges for the transcatheter mitral valve interventions, mainly the anchoring. Obviously, if we look at the aortic valve and the mitral valve, it's a lot different. Aortic valve has leaflet patterns, has annulus, graspings, apical tether, and has calcifications. Mitral valve really has not much of this. The challenges of inflow sealing are quite obvious here. The shape of the atrial sealing zone, then the dynamic changes with the annulus throughout the cardiac cycle, and obviously the preservation of native mitral valve apparatus. And most importantly, or more importantly, the LVOT obstruction, here shown very nicely by CT and screening. Here are the transcatheter replacement devices in humans, more than 700, led by Tendyne, Intrepid, and Tiara. Go through the parade a little bit. Let's start with the transapical Tendyne's, Abbott's Tendyne, Medtronic's 12, Intrepid, and the Neovasc's Tiara. The Tendyne, we all know, it has this design with a tether in the left atrial apex. As you can see here, I love this picture on the left side. You can see this, how the valve is being pulled into the annulus and held by the tether. Ongoing clinical trials are shown here. The global feasibility CE study with 350 patients, up to 40 clinical sites in Europe. The Summit IDE trial was close to 800 patients, up to 80 clinical trials. And then the MAC trial, 30 patients at up to 10 clinical sites in the United States, with 11 being treated. Annular calcification is a vexing problem with significantly increasing surgical risk, challenging anatomies to implant conventional and unconventional prosthesis. And Tendyne TMVR potential shows that by the apical securement via tether and pad, that maybe they can tackle this complex anatomy. This is an image from Paul Saraja. Tendyne in MAC, as the result, is being pulled onto the calcifications. The early experience is summarized here. It is feasible in those selected patients. The early experience is promising. They have a high rate of technical success, very low procedural and 30-day mortality, basically zero, and there's complete elimination of mitral regurgitation. This is Tendyne's revised trial design. As you can see here, a randomization between Tendyne and the mitral clip. And if the heart team sees that the randomization will not be suitable, then the patient's being moved over to the severe MAC cohort and to the non-randomized cohort. So a very interesting trial. The next generation is being worked on, valve and sheath integrated, and there should be a complete retrieval possible. Medtronic's Intrepid TMVR has a very specific design. It has a conformable outer stent that engages in the annulus, and then there is a circular inner stent that houses a 27mm tricuspid bovine pericardial valve, as shown here. It kind of compensates for the movement of the atrium. You can see here the brim moves and virtually no changes within the valve. This is a nice picture of a successful implant with no signs of leak and obviously no mitral regurgitation. The Apollo trial is underway. And you can see here the PIs, Marty Leon and David Adams, with study chair Michael Mack. Also a treatment arm randomization, mitral valve surgery and TMVR. And here you can see TMVR analysis cohort and also a MAC registry. 56 sites have been opened, 700 patients consented, and 180 patients treated. Next generation device will be recoverable and utilize transeptal delivery. Tiara TMVR has been around for a while. It is a very interesting approach, as you can see here. It fits into the asymmetric and multiplanar mitral valve annulus, anchors securely, and due to the low profile, avoids left ventricular outflow tract obstruction, D-shaped and capturing the anterior leaflet, as you can see here. The Tiara 1, 2, and compassionate use data are summarized. If you look at overall here on the left side, you can see that no death in these, no outflow obstruction, 30-day mortality overall, CEC adjudicated 8 with 11.3%, cardiovascular only 5%. The next generation Tiara, the design focus obviously transeptal, reducing the catheter size, reduce overall ventricular footprint of the valve, so it will fit a much larger patient population and anatomies. and maintain current valve hemodynamics. The beauty of all these three devices is summarized here, both for the Medtronic Intrepid, Tiara, and for the Abbott Tendyne. If they are successfully implanted, they virtually eliminate completely mitral regurgitation, which is obviously the goal of this treatment. Moving on to the Transept Er devices, we have Valtech's cardio valve, Edwards M3 Sapien, HighLife, the Evoque, and Cephea system. The Evoque TMVR is the newest iteration of the Cardiac Q device. Transeptal early feasibility study is currently enrolling. It is a transeptal device with 28 French, as you can see here. And you can see the very good news on the right side. Basically, if you look at red, 100% severe mitral regurgitation on the right side. Basically, 100% have less than 1+, with 80% no mitral regurgitation. Very, very interesting result with a very interesting device. Sapiens M3 TMVR system, also from Edwards, uses a valve, which is here. It's a tissue frame of the Sapien 3. It's a knitted PET skirt. Then you have the stent. It is a dock. And then the assembled valve, and the dock encircles the native mitral valve leaflets, followed by the valve delivery. It is transeptal with 20 French. The US Canada EFS study is currently enrolling. This is how it looks in situ on the fluoro. And you can also see here very, very good results, compassionate use and EFS early on. You can see technical success overall if you look at the right side. Very high, 89%. Mortality very low, no outflow obstruction, no device migration, and no conversion to surgery. Here, also the good news, moderate and severe mitral regurgitation altogether in 7.4%. The remaining is mild, moderate, and none. Next, something which is also a dual design device. You can see here the HighLife approach, a valve and a ring. Basically, what you do is you implant the ring subannulally via aortic access, and then you implant the valve via transeptal or transapical approach. It mimics the valve and ring procedure by the placement of the ring prosthesis around the native leaflets, followed by valve delivery within the ring. It is transapical, transeptal, and transapical. This is a moving case example. You can see here the device, here is the ring, and here is the valve in place. What is interesting, obviously, there's no MR left. What is interesting is it has a very low footprint within the left ventricle, so it might be positive for lesser LVOT obstruction. The global feasibility is on its way, both transeptally and transapically in various countries, and the patients are being enrolled. Then the two remaining one is TMVR cardio valve. Shown here on the right side is the cardio valve that basically mimics the Edwards Perimount Magna valve. 7 patients have been enrolled, and not much has been done during the last couple of months. We will see how the company moves forward. And then Cephea, also from Abbott, a transeptal approach. As you can see here, the various design attributes: minimally invasive, chordal sparing. The LVOT obstruction is low, leaflet durability, and it's a low device thrombogenicity. We will hear those very early results with only a few patients, if I'm not mistaken, 4 or 5, but they have been successfully implanted in France. And then some new novel TMVR technologies with a little bit view of the future. The Saturn Technology is a single device characterized by an annular structure on the left side, mechanically connected to a central valve, and then assembled here on the right side, comes from Italy. A solution that might address the challenges and the wide variability of the native annulus sizes by reduction of the size of the mitral annulus and stabilization of the valve within the annulus. Then the altar valve features are shown here. Looks a little bit like a space model. You can see it is a transeptal, transapical delivery system. It has been implanted in humans. This is the first transapical approach in 2018 with 1-year follow-up successful in Montreal. And this is the first in human transeptal altar valve with no significant MR done in New Jersey. And then lastly, the innovative alternative mitral valve solution may be a bridge between repair and replacement. The Sutra TMVR solution, basically Sutra uses a tri-leaflet posterior leaflet design, which actually optimizes and augments the cooptation of the native anterior leaflet. Animal studies are underway. And then the Polaris system, the posterior leaflet augmentation and restoration system. The implant, the delivery, and the anchoring system is shown here, PTFE in the posterior aspect and the anterior aspect. With the delivery system, you can see here a central anchor and 2 side anchors on each side, anchoring the device in the mitral annulus. And you can see here the device in white, the anterior leaflet coapts with the PTFE very successfully in this animal model. And the first patient has been done by Dr. Schäfer in Germany in November 22, 2019. Patient with massive MI reduced to trace. With this technology, this is Dr. Schäfer with a patient. You can see here very nicely and the echocardiogram, and the echocardiogram shown here on this side. Here's the anterior leaflet, and here's the Polaris device. And then the Half Moon project of the Foundry, which is in the early stage, and we haven't seen much of this device, but it is public domain here. This is the patent, and you can see it also addresses a circular or semicircular approach within the left ventricle. So lastly, what are the remaining challenges in TMVR? The patient selection. For TMVR to become a viable therapy, the safety profile must reach that seen with TMV repair. A recent analysis of 203 patients from the Tendyne and the Medtronic study reported an ineligibility rate of 89%. The reasons for exclusion were summarized. However, with improved patient selection, better understanding of how to image for left ventricular outflow obstruction, and a smaller device profile in Tendyne has brought this rate down to down to 30%, which obviously is much, much better than 90%. However, more work needs to be done in understanding patients who are truly ineligible for this technology. Probably, if we look at interventional mitral valve therapy, a toolbox of treatment options will be needed to treat this heterogeneous and complex disease. Either replacement of the mitral valve, or fix and or reduce the annulus perimeter or diameter, eliminate excess leaflet tissue, secure, repair or replace cords, and fix or reduce left ventricular volume. So this is my last slide, and I hope that I could show you some interesting ideas. The field is moving on. We have seen and experienced since 2009 that the reality is cruel, but I hope to be able to have shown you the future is out and the future is very promising. With that, I would like to thank you for your kind attention.
Eberhard, that was really fantastic. Thank you so much. You know, one of the reasons I like these sessions is because it's not often you can go to a talk where you have an expert present you all of the mitral technologies that there are. Usually you go to meetings and you hear a little bit about this, a little bit about that. And they're often presented very much by, you know, people who are involved with the specific devices. So you don't get an overall approach. So that's really a phenomenal talk. I'm gonna pass. I have a lot of questions myself, but I want this, you know, to be about the fellows. So I'm going to pass it on to Sabida to ask her questions or questions from the chat, and then I may, and Antonio will make some comments along the way. Sabida.
Thank you, Dr. Grube, for this excellent talk. It provided us with a great overview of all the different interventions that are available at present. Firstly, if you could answer these questions for us from the audience. The first question to us is about the difference between mitral clip and the carillon, whether it was statistically significant, the findings of 46% versus 33% that was observed.
So question is carillon and intrepid, basically completely
carillon and mitral clip, sorry. Yeah.
Well, oh, okay, so that was the clip and the carillon. This is actually very interesting, and I would like to hear obviously Antonio's and Azim's opinion about this. This is it's a little bit better than a starting point. We do have fairly robust data on the mitral clip, and now with Cardiac Dimensions, remember Cardiac Dimensions is a private company with obviously limited financial resources. These studies are very expensive, but they have started with reduced FMR, and now in the United States with a trial that will answer that question. The reason why I've discussed this a little bit more is that in my view, and that is personal, and I know it is controversial, I think we have been focusing mainly on acute results. And if you look at replacement and the cardioband and millipede and other devices, you look how much is mitral regurgitation being reduced. But we also know that at least in functional MR, the ventricle needs time to remodel, and that's what we eventually would like to achieve, that the ventricle remodels and the left atrium gets smaller. And I think that needs time. It's not enough to just simply say, you know, we've reduced the mitral regurgitation to 0 and then see what's going to happen. Or in other words, if you give them a time, and you can see on the early numbers of the clip in the EXPAND trial that Scott presented, you have, after 30 days, you have early signs of positive remodeling with a reduction of end diastolic volume. Simply the fact that you have longer term results now with the Cardiac Dimensions, since the device has been out for such a long time, we have longer term data. Unfortunately, not many patients, but I think it is a very interesting device, particularly the slide that I summarized, the ease of use. It is, you don't need a lot of skill sets, you don't need surgery, you don't need a lot of imaging. So it is a very attractive approach. If indeed we find the same trend, then this will compare favorably to the clip, because all the other devices that now have to be compared with the clip will probably have a problem or potential problem because the safety data for the clip are so good. And all the other devices are still struggling with that particular endpoint. So I'm very positive of the early promising results. We'll see. The company needs funding, obviously, and we see how far this goes.
Yeah, absolutely. I would agree with that. I would just say from a scientific point of view, to be careful when you see these comparisons made. You know, everybody now accepts that mitral clip is the gold standard per se. It may not be the best therapy, but it's the best we have with the largest amount of data. So all the other companies will try, and you'll see the slides, will say, look at our data compared to what mitral clip data is. And these are, you know, comparisons of completely different groups of patients at times, even though they may be FMR. They're not randomized data. They're not propensity meshed in any way. So that's why you won't see P values. It's just really to give the audience an idea of where their results lie compared to what is the gold standard right now, which is mitral clip.
Yeah.
So going on to the next question, what are your thoughts on the use of combined strategies targeting both the annulus as well as the leaflets, whether you do it simultaneously or in succession? Like, for example, cardioband and then the mitral clip.
Yeah, this is a very, very important and a very interesting question. I have spent the last 4 to 5 years with a wonderful surgical teacher with Steve Bowling, and I continue to work with him. And so I've learned a lot about the annulus. I've learned a lot about the mitral valve, both from a surgical and from the interventional standpoint. I think what the surgeon, and that's a little bit my warning finger, for the surgeons, an annuloplasty is a very short part of a procedure. It can be added, if I may say. You know, you have something, they operate on something primary, or in fact secondary, if they do operate on secondary, and then they put the ring in, which lasts maybe, I don't know, 15, 20 minutes. It's not very complicated, it's not very costly, and it is fairly easy. For us, it's entirely different. So the combined approach, I think, is a very interesting approach. It makes a lot of sense to do a cardioband and the clip, or to do chordal repair together with annuloplasty. All these so-called combo procedures are very promising. Probably we cannot do them in the same session, which is also good for financial reasons and also procedural reasons. But it makes a lot of sense if we do something, for example, the leaflet repair, stabilizing the leaflet repair if the patient comes back in the annulus, or to do a chordal repair and stabilize that with an annulus too. So I think both have their values, and I think in the future we will see more patients with the combo approach, because I think we all realize that probably in the clip population, that at some point they might come back, and then we have to have another option. The best option before you reduce the bridge is probably then annuloplasty, be it by millipede, be it by cardioband, or some other devices that might come out in the future. So I think it is a very promising approach using both technologies.
Yeah, I would maybe add to that, sorry, just from, again, you know, if you look at the data from the Alfieri group, that published their long-term data looking at edge to edge, okay? And it's not randomized, but they looked at their data with just edge to edge only versus when they added a ring to the edge to edge. And certainly if you add a ring to the edge to edge, you have a much more durable result and less recurrent MR. So the concern is if you only do clip, you're treating one of the pathologies of FMR, which is the leaflet tethering, but you're not treating the annular dilatation. So the annulus could potentially still dilate and you can get recurrent MR. So we may see more combination therapies. And maybe the one question I have for both you and Antonio, before I give it back to Sabita, is the fact that we say clip is the gold standard, and now because of COAPT, all the other companies have to compare the results to the clip. Okay. The one concern I have is, you know, if you look at the results of COAPT, as far as complications, as far as residual MR that was left, they're the best results we've ever seen. Okay, very low percentage of important residual MR. Do you think that's, I mean, those results are generalizable? That, you know, everybody can get those kind of results, and if not, you know, what do we do then to improve the results?
Antonio, you have the word.
Yeah, but first of all, Eberhard, congratulations. You really, I listened to one of the best lectures that you gave. And I believe this time for you helped. I mean, you are someone that needs to be used, but you have to employ your intelligence like you did preparing this lecture. So to go, I really like the mitral because, you know, coronary is stent. Everything ends there. Aortic valve is valve. Everything ends there. It's one paragraph chapter. I believe mitral valve, the answer is not going to be the clip, is not going to be carillon, is not going to be the valve. We need at least to have, I would say, 4 devices and use them in some patients, device 1, in another patient, device 2. We cannot pretend that one device will take care of most of the problem. Regarding the combination of cardioband and mitral clip, sounds very interesting. Nevertheless, we have to take into account practical feasibility, cost, cath lab time, etc., etc. Many devices in the field of coronary failed because they don't have applicability. They are rational, make a lot of sense, but they don't have applicability in a wide range. When we make a device, we have to think that the device needs to be sold to everybody, utilized, etc., etc. And these are important limitations that every device in development has to take into account from the very beginning, because there is no point to develop a device which is too complicated to be utilized.
So thank you very much, Antonio. That was very kind of you. And this coming from you with your intelligent head means a lot to me, obviously. Azim, when you look and you try to be as good as surgery, I think it is very reasonable to differentiate between the two disease entities, between functional and degenerative. But remember, in degenerative, all surgeons finish their repair procedure with a ring. They stabilize the annulus. And it is very often forgotten that Professor Alfieri, who I admire deeply, never did, as you said, never did the clip alone. He did it at that particular point when he started it. He stabilized it with a ring. We try to do the same thing, achieve the same result with one part missing, which is the annulus. As Antonio mentioned, it has financial impact and has procedural impact, so we cannot duplicate it. But I think at some point it is very necessary that we stabilize the ring. But it's easier said than done.
Go ahead, Sabina.
The next question is, we discussed thrombogenicity. So what are recommendations regarding use of antiplatelets, anticoagulation, post-implant? Have you noticed a significant amount of device thrombosis?
Yeah, maybe I would like, I can answer that question, but maybe Azim, you can answer that question better because number one, you have more experience and you're in the middle of it. We have been a little bit slow here in Europe on it. I think there's no question that we learned painfully, as you mentioned, the thrombosis issue in mitral valve. And it has various aspects that I would like to take Azim's knowledge of design-wise, procedure-wise, and then of course, patient concerns. So maybe Azim can address that better.
Yeah, absolutely. I think that's a great question. I mean, I'll give you a very brief answer. I'd suggest we have a really good review in JACC Intervention on anticoagulation, antithrombotic therapy after mitral devices and after mitral procedures. I would suggest having a look at that. But basically, when it comes to the replacement devices, because of their size, because of the bulkiness of these devices, because of the fact that they create often dead ends and areas where there's no washout. Also the fact that, you know, there's so much metal and the leaflets are so high, thrombosis is a real issue. And I think actually it's almost, you know, that elephant in the room that nobody talks about when it comes to replacement. It's probably, to me, the Achilles heel that's going to be the most challenging part to resolve with replacement. So we've seen that thrombosis of these valves is more common than it is with aortic valves and with TAVR. It's not 100%, but it's in the high single digits. And when it occurs, it can be very dramatic for patients, as in they can have embolic events or it can affect the function of the valve. So for all these studies that we're doing now with the valves, it's almost, I think, 100% that we have to anticoagulate patients after the procedure. So we are not using just antiplatelet therapy, but using full anticoagulation, but even high end of anticoagulation. So INRs of 2.5 to 3.5 actually around about 3, slightly higher than 3. The other issue we've also realized is, during performing these procedures, you need to keep patients also well anticoagulated. And some of the devices and companies have suffered from that as well, because there have been a higher incidence of vascular complications afterwards because of bleeding. So you've got to a little bit, balance that. You need to keep patients well anticoagulated so they don't thrombose the device, but you have to be sure they don't bleed excessively.
Sabina, can I have one question to Azim? Because I'm afraid that I cannot ask him and the meeting is finished. One quick question, because I mentioned Ancora and you are one of the PIs for the heart failure reduced AF. What do you think or what is your provision or your potential on this device approach and of this device?
Yeah. We're very optimistic, Eberhard, especially now that the company's focus has moved away from reducing mitral regurgitation to treating heart failure. There's really no competitor device in the field of heart failure and reducing LV dimensions. So we've treated a few patients here in Monty. The procedure takes 2 hours. Our patients have gone home the next day. So like you would after a mitral clip or TAVR procedure. And the results have been dramatic. We treated a 35-year-old patient who is asymptomatic after the procedure. So we're very interested. We think it has a lot of potential. And we're investing a lot of time in trying to find patients with it. And what really has helped us is that our heart failure group has become convinced. Right, yeah. So it's their patients and they believe in it, and it also, I think, goes back to some of the comments. One of the participants asked. We really do have a multidisciplinary team here when it comes to these kind of patients. When it comes to mitral, tricuspid, heart failure patients, we discuss it as a team. We have our imaging team involved. We have surgery involved, and most importantly, the most important group has become heart failure. Okay, I mean, if you're going to think about building a strong mitral or tricuspid program in your institution, my advice is to build a strong relationship with your heart failure team, because they're the ones who will help feed your program and help you evaluate these devices in the right group of patients.
Alluding to this, Azim, remember on your journal club when I joined the discussion from Zurich, which obviously everybody claims now to be detecting it, and the Swiss guys have done it. The collaboration between the pathologist and the cardiologist basically was a breakthrough in looking at this coronary disease, not only being a pulmonary disease. So these cooperations are becoming more and more important, and it is very unfortunately that still in some institutions this is not being fully understood yet.
Yeah, absolutely. Sabina, any burning last questions? I don't want to keep you too long. I know you probably have to go to the cath lab.
Sure. We have a few questions follow up regarding the anticoagulation. People want to know if it should be done indefinitely and if there is a role for NOACs.
So I would say yes for now, indefinitely, and probably no role for NOACs at this stage. We've seen thromboses with NOACs on these large valves. So it needs to be Coumadin and with INRs 3 or above.
Okay. The next question is about the approach. Transfemoral, transseptal seems to be the preferred approach, but probably not feasible in all patients. So when it comes to transapical, obviously there is the question about myocardial damage, as has been seen in TAVR. So when would you think about a transapical approach, and in which patient subgroup?
Asking me?
Yeah.
Well, it's the same lesson, basically. It's the same lesson that we learned in TAVR. You begin with the transapical approach because it's a straight axis. You hopefully not need to take the sickest patients as far as ejection fraction is concerned, even though this is an important question. But it's a straight shot, to the mitral and to the aortic valve. Eventually, I think eventually, I think the future will be transeptal, transapically. It has to be done easier. The delivery size has to come down. Even though the delivery catheters at the very beginning, as in the TAVR devices, are bigger, but today we have means to close an ASD, or but I think eventually the transeptal approach will be the preferred option, because you leave damage behind with the transapical approach, apart from discomfort and pain. So in my view, even though I was questioning this a little bit on the road during the last years, but I think eventually it's going to be, the breakthrough will be a transeptal approach. And as you can see, all companies basically are focusing on a transeptal approach because it's less damaging. I would not believe, unless you have really very specific mitral valve abnormalities, that you wouldn't be able to use a transatrial, a transeptal approach. But usually, you know, all these patients fit into the transeptal category. I don't see any restrictions as far as that approach is concerned. It's definitely the preferred approach.
There's another question about use of these approaches in acute MR in the setting of ACS. Is there a role in acute mitral regurgitation?
Acute mitral regurgitation, so there is a role. I think right now there are more and more case reports and small case series of mitral clipping used in patients with acute ischemic MR who are even in cardiogenic shock. There's really two groups of patients here. There's the group of patients who actually have a mechanical damage of the mitral valve, so ruptured chordae or ruptured papillary muscle, who are not candidates for surgery and are too high risk for surgery because they're in shock. And then there's another group of patients who actually post-MI have an acute form of ischemic MR with very severe MR where they struggle to actually get out of their cardiogenic shock. So those are the two groups of patients. It's still a new indication that's still growing. So you'll only find case reports. I think we're going to try and end with a final question to you and Antonio. So I think, you both said we need a toolbox of devices, right? So basically our toolbox is going to be a edge-to-edge device. We won't say give a name, whatever the device you like, a annuloplasty device, okay, a chordal device, and replacement. Those are our four devices, Eberhard and Antonio. Okay, we're in 2020 now, okay? I want your crystal ball predictions, okay? In 5 years from now, in 2025, what percentage of procedures will be done with each device? And then that's where we'll end.
Antonio, would you like to start?
I would say 40% with the clip, 10% with the cord, 20% or 15% with the mitral valve, with the transcatheter mitral valve, and the rest, I don't know, they will be occupied by whoever is leaving some place. But I don't think the transcatheter mitral valve will take more than 30% because of the various problems, including anticoagulation, thrombus, etc.
So I would like to answer this probably basically the same way, but I think I would like to differentiate, Azim, between primary and secondary.
Okay.
In secondary, there's no question that I think anyway, no question, but we need some kind of annular reduction device, be it subannular, supraannular, or intraannular. But I think the clip device will, in the very, very sick patients, will remain being stabilized maybe with an atrial or with an annular device that stabilizes. But I think the clip will be reserved for the very sick patients because it has been successful. It's going to stay. But on the other hand, we try, I think, to prevent the patient in FMR, try to prevent the patient to enter that stage. So with an annular device in an earlier stage, grade 2 maybe, if that's possible, it will be possible, then I think the annular approach will be more dominant than the clip. The clip will be, will be reserved for the very sick ones. On the degenerative side, I think it's clear where the clip will be there only for the suitable anatomies. Other than that, I would like to use a stabilizer in the annulus together with the chordal repair. Okay. Percentage-wise, it's hard to say.
You in all of that, Eberhard, I'm going to push back one last moment. You didn't mention much replacement.
Yeah.
What role is replacement going to have?
I tend to agree with Antonio. Whether we ever reach 20%, if we have, look, and again, FMR and DMR. In FMR replacement, we hope to avoid by either treating the patients earlier with an annuloplasty or later with a clip. So I don't see many patients, percentage-wise, many patients with a replacement. On the degenerative side, if there is no ability to repair, then it is going to be the only remaining option. My percentage would be, the high rate would be 30. I would believe between 20 and 30% at the most. Okay,
great. Thank you both. I think we've run a little bit over time, but it was a really stimulating discussion. Lots of great comments from the chat and the participants, especially thanking you, Ebba, for such a great lecture, and Antonio for all your comments. Sabina, thank you. You did a great job with managing all the questions. I really appreciate it. Thank you all. Have a great day.
Thank you very much, Antonio, and thank you very much, Sabina. Ciao, ciao.
Okay. Thank you. Bye-bye.